Good afternoon, one and all, and welcome to the 10th session of Academic Cover, continuing Professional Developmental Lecture Series organized by the Clinical Society Base Hospital Mahiyanganaya together with the Branch Union of Government Medical Officers Association. And we are gathered here today to enhance our clinical knowledge on yet another crucial topic pivotal in our patient care. And to do so, we have Dr. Buddika Rathninda sir, Consultant Radiologist, Base Hospital Mahiyanganaya, who has graciously accepted our invitation to share his knowledge and valuable insight. Now, I kindly request upon Dr. Rohit Amaravitarana to introduce our key speaker. Over to you, sir.
Thank you. Good afternoon, everybody, and you all are welcome to the academic session, academic hour organized by Mahiyanganaya Clinical Society for the next lecture. And it is my duty to introduce today's speaker, Dr. Buddika Rathninda, Consultant Radiologist, Base Hospital Mahiyanganaya. Dr. Buddika Rathninda, MBBS Peradeniya, MD Radiology, Colombo. He worked as an acting consultant radiologist at Kurunegala PGH before coming to Mahiyanganaya, and he worked here more than 3 years as a consultant radiologist. And you all know he is an excellent wildlife photographer, and he is going to talk on a very interesting topic, one of the very useful topic for you all, X-ray interpretation of acute abdomen. And over to you, Dr. Rathni.
Thank you for kind introduction, Dr. Roy. I'm going to talk about X-ray interpretation of acute abdomen today. As medical practitioners, we encounter a lot of cases of acute abdomen in day-to-day practice, so I choose to do this presentation for you all. What is acute abdomen? Acute abdomen is a clinical condition which is characterized by severe abdominal pain unrelated to trauma, and it requires clinician to make an urgent therapeutic decision. So, acute abdomen is the most frequent reason for presentation at the emergency department. What are the causes? You can see in this diagram, there are a lot of causes mentioned in this diagram. Some of them are surgical causes, and some of them are medical causes. And these causes are labeled according to the quadrants of the abdomen. So I'm not going to discuss each and every pathologies in my lecture, and I will discuss each of these conditions. Their X-rays are very important. Why is imaging is important? The first reason, the indicated management may vary from emergency surgery to reassurance of the patient. And imaging helps clinician to decide whether to go for a surgery or not. And this prevents delaying necessary treatments or unnecessary surgery. So imaging basically important to the clinician's decision making. And the second reason is clinical presentation is often non-specific. Both surgical and non-surgical diseases can present as similar clinical history and symptoms. So for differentiate these surgical and non-surgical diseases, we need to go for imaging. And thirdly, laboratory findings. Laboratory findings are equally non-conclusive, so you need to go for imaging. Okay, what are the imaging methods in acute abdomen? Conventional radiography, which is I am going to discuss today in this presentation. And other investigations are ultrasound scan, CT scan and MRI, which are actually cross-sectional studies, and GI contrast studies like upper GI contrast studies, barium minima, etc. Conventional radiography is an important initial imaging modality in acute abdomen, and it is less specific and low diagnostic value. That is the reason we are not doing X-rays for every and each patient who are coming with acute abdominal pain. So we are doing this for selected patients. So this diagram shows how the X-ray is produced. There is a X-ray generator here where the X-ray beam is produced, and X-ray beam goes through the region of interest, here the abdomen, and some of the X-ray beam absorbed from the abdominal organs and some of the X-ray scatters, right, and rest of the X-ray beam goes to the detector system and produce the X-ray. So why these different densities? This is because the different type of tissues absorb different amount of X-rays, right? If you this is called actually attenuation coefficient. There is some physics, and if you consider gas, the most of the X-rays goes through the gas and reach the detector system. Therefore, you see black color in the X-ray. And if you in the other spectrum, if you take metal, the most of the X-rays scatters, don't reach the detector system. So in that case, you will get a white color image. So in so these two are the end spectrum of these densities. So in gas, you will see it as black. Here in bowel gas, you see black color in bowel gases. And fat, you will see dark gray. Soft tissues, number 3. Here the liver, this shows the liver. It is gray color, light gray color. And bone and calcifications are white. These are the bones, pelvic bones. These are white. And the metal are intensive white. Here you will see this belly ring. This is intensive white. So this is the range of densities you will see in an X-ray. Okay, I have put this normal supine abdominal X-ray to show you the anatomical structures you will see in abdominal X-ray. So this is the second X-ray is the same X-ray and with labeling. So we'll look into these structures what we can see in abdominal X-ray. Here I will show you. Here there's a triangular density. This is the liver shadow, and you can see the low edge. And here the spleen, lower pole of the spleen you can see. And on either side of the vertebral column, here and here, you will see the renal shadows, both kidneys. And in the pelvis, what is this? This is bladder shadow. So these are the organs you can see in the abdominal X-ray. And also you can see on either side of the vertebral column, on either side, here and here. These are psoas muscle. And also you can see bowel loops, the small bowel loops. You can see here central, few small bowel loops and large bowel loops. This is the ascending colon with feces, and this is the transverse colon. Likewise, you can see the large bowel and the small bowel in the abdominal X-ray. So you have to keep these structures in mind, because when we are going to discuss pathologies, this is very important. Okay, what are the radiographic views we do in a patient with acute abdomen? This is called acute abdominal series. So this includes 3 X-rays. Okay, the first one is the supine abdomen. Supine abdomen, actually it is the most important X-ray in an acute abdominal patient, because most of the information can be obtained from this X-ray. And this diagram shows how it takes. The second X-ray is erect abdomen. Erect abdomen is important because when you are going to assess air fluid levels, especially in bowel obstructions, you need to take erect abdominal X-ray. The third one is the erect chest X-ray. Erect chest X-ray is very important because it is the most sensitive view for pneumoperitoneum. And second thing is, the various chest condition can mimic the abdominal conditions like pneumonia, pulmonary infarction, pneumothorax. Those conditions can mimic the abdominal acute abdomen in presentation. So better to have a chest X-ray. So by taking a chest X-ray, you can exclude these chest conditions. And the third reason is it acts as a baseline, because after doing a surgery of a patient, if patient develop a post-operative complication, you can compare this with the previous chest X-ray. So these are the reasons, and these are the X-rays you take in an acute abdominal patient. If patient cannot stand, right, then in that case you have to modify this series. So as in previous series, you take supine abdominal AP film, and instead of erect abdomen and the erect chest X-ray, you take left lateral decubitus and supine chest X-ray, because due to some reason, if patient can't stand, you have to do these three. So you have to assess whether patient can stand or that status. So left lateral decubitus view is important to assess the fluid level and the pneumoperitoneum, and supine chest X-ray is important to assess the chest conditions. So in taking left lateral decubitus view and the erect chest X-ray, you need to concern this point, because you have to keep the patient for 10 minutes before obtaining these two X-rays. So you have to write down the indication in your request form if you want to look for pneumoperitoneum, because it needs some time to accumulate air under the diaphragm. So sometimes our radiographers, in the absence of this indication, they take erect abdominal X-ray without keeping the patient for 10 minutes. So I am going to approach abdominal X-ray in acute abdominal patient following these major categories. The first one is bowel gas pattern. And so I am going to discuss what are the abnormal bowel gas patterns in this lecture. And the second is the extraluminal air. Extraluminal air means air outside the bowel loop, it's abnormal. And third, tissue masses. And fourthly, calcification, radiopaque calculi, and foreign bodies. I am going to discuss all these in rest of my presentation. Okay. Before moving into interpretation of abnormal gas pattern, we need to look for normal gas pattern in a normal abdominal X-ray. So if you consider stomach, almost always you see air in the stomach, right? In this crop image, you will see stomach in the left upper quadrant, and the lower part of the stomach crosses the vertebral column, right? But it may be not visible if the stomach is either completely fluid filled or completely empty. And what is the normal appearance of small bowel? Usually you see only 2 to 3 loops in a normal abdominal X-ray, because in intestinal obstruction you will see more bowel loops. And the important thing is the central, these small bowel loops are located centrally, and these loops have a thing called valvuloconnivantes. Valvuloconnivantes means, here you can see in this picture, thin white lines extending across the full width of the lumen of the bowel loop. So that's how you differentiate this from the colonic hostrations. So in this loop, you can see a white line extending from this wall to this wall, right, across full width of the lumen. How you see large bowel in a normal X-ray? Usually, almost always air you see in the rectum. So it's very important, because in obstruction you will not see air in the rectum. And varying amount of gas is seen in rest of the large bowel. In here you can see the ascending colon. This is the transverse colon. This is the descending colon. So you will see air in this colon, rest of the colon. And important thing is these the retroperitoneal part of the colon. That means ascending and descending colon has a constant position in X-ray. That is because these two part of the colons are retroperitoneal, and rather than the transverse colon and the sigmoid colon, because transverse colon and the sigmoid colon has a mesentery. Because of this mesentery, this sigmoid colon and the transverse colon take various positions. So when you are looking at the normal X-ray, when you are finding large bowel, most of the time ascending and descending colons are fixed, and other this transverse colon and the sigmoid colon position can be varied. And rather than the small bowels, the large bowel loops are peripherally located. This is very important. And also the hostrations. As I mentioned earlier, in hostrations, these are the hostrations. These are the hostrations. In here, in hostrations, it doesn't extend from wall to wall. That is a different feature from the small bowels. And lastly, the fecal material. If you see fecal material, that is the large bowel, right? Because normally you don't get fecal material in the small bowel. Here, here you can see mottled appearance. That is feces, actually fluid feces. This is, and in transverse colon you see like mass-like areas, white color. These are actually solid feces. And there is another thing called 369 rule. What is 369 rule? 369 rule is the maximum diameter of the normal bowel loop. If it is a small bowel, we take it as 3 centimeters, large bowel 6 centimeters, and cecum 9 centimeters. This is also very important. If you consider the normal fluid levels, you see always you see a fluid level in the stomach in erect X-ray. And if you consider small bowel, you see only 2 to 3 levels of fluid level, that is normal. This, you need to keep this in your mind, because in bowel obstruction you will see more than 3 fluid levels. In large bowel obstruction, in large bowel normally you don't see fluid levels. These are the actually normal findings in a X-ray. Okay, now I am going to discuss the abnormal gas patterns. I have divided this into two parts, the functional ileus and the mechanical obstruction. Functional ileus mean one or more bowel loops become aperistaltic. You don't see peristalsis in these bowel loops, and these bowel loops are dilated. So this is very important, because you need to differentiate this from the mechanical obstruction. So functional ileus can be divided into generalized ileus and the localized ileus. And mechanical obstruction we can divide into small bowel obstruction and the large bowel obstruction. So out of these topics, first we'll discuss generalized ileus. What is generalized ileus? Generalized ileus means hypomotility of the GI tract. That means both the small bowel and the large bowel are involved, and there is no mechanical obstruction. The most commonest cause is the post-operative ileus. And these are the other causes: electrolyte imbalances, sepsis, generalized peritonitis. And if you're taking X-ray to look for ileus, ideally you have to take 2 X-rays, either supine abdominal X-ray or chest X-ray or left lateral decubitus film. So here it's a patient with generalized ileus, and here you can see centrally you can see distended large bowel loops with valvular connivantis. These are the distended small bowel loops, and peripherally you see large bowel loops, and you don't you will see air in the rectum. So in mechanical obstruction you don't see air in the rectum, and this erect abdominal film you will see 1 or 2 few air fluids levels. If you do a X-ray, erect X-ray abdomen, you will see 1 or 2 fluids in erect abdominal X-ray. But in mechanical obstruction, you will see more than 3 fluid levels. This is also very important. If you see what is a localized ileus? Localized ileus means 1 or 2 small bowel loops are dilated. You see only dilated 1 or 2 bowel loops. This is called sentinel loop. Right, this is because of due to a local irritation. So you can get an idea about the local irritation. If you see a locally dilated bowel loop in abdomen, then you can think that there is a inflammation going on. So this table shows you the cause of the ileus with its location. So if you see a ileus, that means locally dilated, focally dilated, this locally dilated bowel loop in right upper quadrant, that means you need to suspect acute cholecystitis. And in acute pancreatitis, you will see the sentinel loop in left upper quadrant. And likewise, an acute appendicitis, you will see right lower quadrant. In the diverticulitis, you will see this loop in the left lower quadrant. So, the first X-ray. First X-ray is a patient with acute appendicitis. Usually, we don't do X-rays for diagnosis of acute appendicitis. Here, there's a green color asterisk mark. Shows you a focally dilated ideal loop here. And what is this? This is the ascending colon. It is normal. This is fecal filled ascending colon. And this is a patient with acute appendicitis. The second X-ray, the supine abdominal X-ray shows the where is the this sentinel loop. It is in the left upper quadrant. That means it indirectly says this patient may have acute pancreatitis. So you need to do further imaging. This is the importance of local ileus. Right. What is the colonic cutoff sign? So during this lecture, I am going to discuss lot of signs, radiological sign. This is one of the signs. And colonic cutoff sign I discuss with the X-ray. You see gas column in the large bowel. This transverse colon, and there is sudden cutoff here at the splenic flexure, and you don't see air beyond this point in the descending colon. Earlier I said that you will see air every time in the ascending and descending colon, and those are fixed position. So you don't see descending colon air here. So this is called colonic cutoff sign. The colon cutoff at the splenic flexure. So this is mostly described with patients with acute pancreatitis. So this is a patient with acute pancreatitis, and the reason they said is this inflammatory exudate you see in acute pancreatitis goes through the phrenicochoric ligament up to the this splenic flexure and causes either spasms or mechanical obstruction. So, but this colonic cutoff sign is not specific, because it is seen also in colonic carcinoma, inflammatory bowel disease, as well as in the mesenteric ischemia. So this second X-ray, supine abdominal X-ray, shows you this is the dilated transverse colon. Here there is sudden cutoff of air column. Right? This is a patient with carcinoma of colon. Okay, so you need to remind this sign. And moving into the next topic, small bowel obstruction. Small bowel obstruction is a condition where the lumen of small bowel is obstructed. This is either due to extrinsic, due to adhesions, that is the most common cause, and masses, congenital malrotations, and can be intrinsic, like inflammatory strictures, ischemia, tumors, gallstones, and the foreign bodies. What do you see in small bowel obstruction? Actually, X-rays are 50 to 60% of sensitive. You have to keep this in your mind, because X-rays are not 100% sensitive for small bowel obstruction. So you can't diagnose every time small bowel obstruction by X-ray. So that means you can't exclude a small bowel obstruction. So these patients can have normal X-rays, and signs appears after 3 to 4 hours and marked after 12 hours. So in supine X-ray, you will see in this is the supine X-ray, and you will see dilated bowel loops with valvular connivantes. I described valvular connivantes are there, centrally placed bowel loops, and these bowel loops are dilated. These are small bowel loops. And other important thing is, if you see the large bowels, as I told you, large bowel loops are fairly fixed. So if you see large bowel loops, you don't see air in the ascending colon or transverse colon or descending colon or rectum. That means there is a complete obstruction at the small bowel level. And this is the erect abdominal X-ray. You see, what is the difference than the normal X-ray? Here you see multiple loops, air fluid levels, multiple air fluid. Here 1, 2, 3, 4, right? Multiple air fluid levels, This is called step ladder appearance. And the level of obstruction indicates the number of dilated small bowel loops. So you don't have to have bowel loops, dilated bowel loops everywhere in the X-ray. So if the obstruction is higher, that means jejunal level, you will see small level of bowels, dilated bowels. If the obstruction in the ileal level, you will see more bowel loops, dilated bowel loops. So this is the only appearance in small bowel obstruction. We usually see this X-ray findings as small bowel obstruction. This is not the only appearance you see in small bowel obstruction. There's a sign called string of pearl signs. String of pearl signs means actually this is diagnostic. This is diagnostic of small bowel obstruction, and this sign you see in only in upright or erect abdominal X-rays. And this is because in intestinal obstruction, the proximal bowel loops fill with fluid initially. So the residual intraluminal gas collects as small air bubbles in between the valvuloconicanthes. So you have to have upright or decupitous abdominal X-rays to collect these air bubbles in between the valvuloconicanthes. This diagram shows the air bubbles in superior wall of the small intestine. So these 4 X-rays shows you the string of pearl sign. You will see here, if you see here, this first X-ray, you will see multiple small radiolucent bubbles like densities continuously. Right, this is called string of pearl sign. Here also you can see multiple radiolucent bubbles like appearance, like a string. Here also you can see. Here also you can see. So in this X-ray, the first X-ray, you don't see dilated bowel loops or the first appearance. So, but if you see this sign, that means there is a small bowel obstruction. This is diagnostic. And this is also another type of presentation in small bowel obstruction, gasless abdomen. Gasless abdomen means the paucity of gas in abdominal radiography. And that means you don't see much gas in the bowel loops. So small bowel obstruction is one of the cause, and it implies more long-standing obstruction of ischemic small bowel. Here in this X-ray, the large arrow shows you the paucity of small bowel loops. You don't see much small bowel loops here. And small arrow shows the few amount of air in the ascending colon. Right? This is a patient with small bowel obstruction, and this is a coronal image of that same patient. Shows you these are dilated. These all are dilated small bowels, but it filled with fluid. That's why you don't see these loops in X-ray. And here you see fecal materials in ileal loop. This is called small bowel fecal sign, and obstruction is ileal obstruction. So that this is another way of presentation of small bowel obstruction, but this sign also not specific. So you have to always correlate clinically with the patient's history and examinations. And there are other causes which cause gasless abdomen. These are ascites, acute pancreatitis, gastroenteritis, large abdominal mass causing displacement of the bowel loops, high obstruction, etc. These are 2 X-rays. The first X-ray is the AP X-ray of a neonate with the esophageal atresia. So in this X-ray, you will see here, this is the NG tube. I think you can appreciate this. This NG tube is stopped in the mid thorax level. So that means there is a esophageal atresia. NG tube doesn't go beyond that point. And usually these esophageal atresia babies associated with the transesophageal fistulas. So here what do you see in the abdomen? Do you see air in the abdomen? No. You don't see air in the abdomen. That means this patient is a patient with esophageal atresia, but there is no distal transesophageal fistula. If you see a distal transesophageal fistula, then air can come into the bowel loops. So this is a patient with esophageal atresia with no transesophageal fistula. This is also another case of gasless abdomen. This is a patient in infant What is the difference between this X-ray and this X-ray? The first X-ray and the second X-ray. If you, right, both belongs to infants, right, neonates. The second X-ray, you will see bulging of your properitoneal lines. There are a radiolucent line called properitoneal line. So if you see this, you see a bulge abdomen, right? This is because, and you see few loops of bowels in central abdomen. That is floating bowel loops, right? This is a patient with ascites. In ascites, in babies, the properitoneal line, the line and the abdominal wall bulges out. Not like this. This is another case for gasless abdomen. So next 3 slides I will discuss some of the etiologies for small bowel obstruction. So I have discussed small bowel obstruction. Now I am going to discuss the etiologies. So usually you don't see etiology in X-rays. So if you want to look for the cause for obstruction, you don't do X-rays. You go for CT, right? That's what we are doing. But sometimes you will see X-ray findings for this underlying cause. So this is an interesting topic, gallstone ileus. The gallstone ileus is actually uncommon, and what happens is you get a fistula in between the biliary tree, that the gallbladder and the gut, because of this chronic cholecystitis, and one of the gallstone goes through this fistula and stuck in the terminal ileum, giving rise to small bowel obstruction. So this is called Wriggler's triad. Wriggler's triad consists of 3 signs. One, the first X-ray you can see dilated, obviously you can see dilated bowel loops. Now you know how to diagnose small bowel obstruction. And you don't see large bowel, yeah. So this is a patient with small bowel obstruction. And if you see the second X-ray, you will see, I don't know, you can see these lines. There are radiolucent branching lines in the hilum of the liver. Those are air between the biliary tree. This is called pneumobilia. I will discuss this later. And the number 3 is the impacted gallstone. This is the ectopic impacted gallstone. So you will see these 3 signs. If you see these 3 signs, you can diagnose this because of the gallstone ileus. And the second thing is the intersusception. It's mainly seen in children. Ileocolic intersusception is the commonest. In adults, if you see intersusception, you need to look for lead point. That means you need to look for cause for intersusception. So in radiography, ideally we don't do radiography X-rays to look for intersusception. What you do is ultrasound. Ultrasound is actually 100% sensitive. So you do ultrasound. And in radiography, you will actually not diagnostic. So you will see 2 signs. The first X-ray, first X-ray you will see a soft tissue mass like round mass like thing below the liver. This is the liver, below the liver. And thin layer of air around this, right? This is due to intersusception. This is soft tissue density. Usually ileocolic intersusception are seen in where? Right upper quadrant. Ileocolic type of, if a pediatric patient comes to us, we first look at the right upper quadrant, because in pediatric patients the ileocolic intersusception are the most common. And in the second X-ray you will see a, what do you see? You will see a crescent sign. Crescent means the shape of the crescent, you see a air. This is the air between 2 bowel loops, right? The intersusceptum and the intersuscipiens. You will see air, and actually these are subtle findings, and you don't do X-rays to grab these radiologic findings. The third thing is incarcerated inguinal hernia. In incarcerated inguinal hernia also we don't do X-rays, but you do X-rays to identify small bowel obstruction. So in that X-ray you can sometimes elicit these incarcerated inguinal hernia. Okay, this is the supine abdominal X-ray of a patient with small bowel obstruction. You can see dilated small bowel here, right? And you don't see large bowel here. So this is small bowel obstruction. So if you see, usually you don't see bowel loops below the inguinal ligament. In X-ray, below the inguinal ligament, you don't see bowel loops. So inguinal ligament extends from the pubic symphysis to this anterior superior iliac spine. So iliac, from here iliac spine to the pubic symphysis. So if you see a bowel loop below this level, then you can say there is an inguinal hernia. So on right side, can you see a bowel loop? In left side there is a bowel loop. Here this is the bowel loop, and here this label, this image. Here you can see the bowel loop on left side, that is below the inguinal ligament. On right side you don't see a bowel loop. This is a patient with incarcerated hernia. And the second X-ray is patient 3-month-old baby present with the small bowel obstruction. In this X-ray also you can see dilated bowel loops, and also number 2 here, right? I don't know where this is the penis, this is the scrotum. You may see the bowel loop here in the inguinal region. This is a patient with inguinal hernia. Okay, now the second topic under the mechanical obstruction, it's large bowel obstruction. Large bowel obstruction is the dilatation of the colon from point backwards, and site of the obstruction is possible to identify in X-ray, because in X-ray large bowel loops are not overlaps, but small bowel loops are usually overlaps. So in small bowel obstruction it's very difficult to say, but in large bowel loop you can say the site of obstruction looking at the bowel loop. And little or no air in the rectum or sigmoid, and you don't see air fluid level. And if the ileocecal valve is competent, you don't see air in the small bowel loops. So if the ileocecal valve is competent, you see air in the small bowel loops. So these are the causes. Most common cause is the carcinoma. Out of these causes, you only see volvulus and the hernia in X-ray. Other causes you can't elicit in X-ray. So I have already right. This is a patient X-ray, erect X-ray and abdominal X-ray showing large bowel obstruction. So where is the obstruction? You can see, looking at this X-ray, you can tell the obstruction. Here you can see this is the transverse colon, right? This is the descending colon, and there is a cutoff of air, right? And so from beyond this point you don't see air. This is a descending colon, large bowel obstruction at the descending colon, and colonoscopy they are found to have circumferential growth in the descending colon. So out of the etiologies, I have discussed hernias, and the other etiology for bowel obstruction you can see in X-ray is the volvulus. So speaking about the large bowel volvulus, there are two types, sigmoid and cecal volvulus. This is very important because X-ray shows characteristic features for these volvulus. So you can diagnose with X-ray large bowel volvulus. The most commonest type of volvulus is sigmoid volvulus. It accounts for 5% of large bowel obstruction and 60% of the intestinal volvulus. What are the plain radiographic findings? I'll explain with these images. So the first X-ray, and these all three X-rays shows your inverted loop of bowel loop. This is an inverted loop of U-shaped bowel loop, and most important thing is it is a ahostral bowel loop. You don't see normal hostrations in this bowel loop. This is very important. And because of the obstruction at the sigmoid level, you don't see air in the rectum, and also the large bowel loops proximal to this obstruction shows dilatation. So in this X-ray you will see large bowel, dilated large bowel here. In this X-ray also you see dilated large bowel here. And also there are few signs which explained in books about sigmoid volvulus. Those are the coffee bean sign. Coffee bean sign, I know you are very familiar with that. This is the coffee bean sign. Coffee bean sign means it resembles the coffee bean, because in this loop you will see a thin peripheral echogenic lines and thick echogenic line here, like resembling this coffee bean. And the second X-ray you can see converging of three lines. Can you see the first line, the second line, the third line? In this one also first, second, third line. Converging in these three lines into the pelvis where the obstruction is, this called Freeman-Dahl sign. And also the third X-ray shows you two signs where these dilated bowel loops actually overlap the liver shadow. right here. This is the liver, and it overlaps this distended loop. It's called liver overlap sign. And also, if you see closely, this apex of this bowel loops goes above the transverse colon. This is called northern exposure sign. These are some signs described for sigmoid volvulus, and these are characteristic signs. So you can identify sigmoid volvulus confidently in an X-ray. So the second type of volvulus is the cecal volvulus. Actually, it's account for 2 to 3% of intestinal obstruction, 10% of the intestinal volvulus. So this is less than the sigmoid volvulus. And what are the X-ray findings? So here in these 3 X-rays, what do you see? Do you see a inverted loop of bowel here? U-shaped bowel loop? No. You see a dilated large bowel loop here, here, and here. And the long axis actually lies from the pelvis, that means right lower quadrant towards the epigastrium or left upper quadrant, towards the epigastrium or left upper quadrant, here also like same. And the important thing here is, can you see the host regions here? These are the host regions, right? These are the host regions. These are the host regions. So in the cecal volvulus, you see host regions. And other important thing is, because obstruction is at the cecal level, the other large bowel loops you don't see air. But in sigmoid volvulus, you see dilated proximal bowel loop. Transverse colon and ascending colon are dilated. Here you don't see dilated ascending colon, transverse colon, descending colon. So these are the signs you see in cecal volvulus, and you can differentiate cecal volvulus with the sigmoid volvulus. Okay. This is also very important. If you see a dilated stomach in an X-ray, you get an X-ray, and if you see a dilated stomach shadow, and what are the causes? These are the causes for dilated stomach. The first 3 are very important: mechanical gastric outlet obstruction, acute gastric dilatation, and gastric volvulus. And I have put the normal X-ray here to compare the dilated stomach and the normal stomach. The first X-ray, this is a normal abdominal X-ray. I think you can see normal abdominal X-ray. This is the normal stomach. And here, it's obviously the stomach is dilated. So, this is a patient with gastric outlet obstruction, and this endoscopy found to have a malignancy. So here you can see a distended stomach, and beyond that level, can you see the air in the other bowel loops? You don't see air in the rest of the bowel. You see only air in this distended bowel. That means there is a complete obstruction at the gastric outlet obstruction level. The second X-ray. The second X-ray also shows you a dilated stomach. So obviously you see a dilated stomach. So this second X-ray belongs to a patient with acute gastric dilatation. Actually this entity is very rare, and sometimes we are not aware about this entity, and it has a high mortality. Pathogenesis is poorly understood. There are several causes: eating disorders like bulimias, right, and medications, electrolyte imbalances, gastroparesis, and diabetic ketoacidosis. These are the causes for this. The important thing is, if you don't decompress this stomach, this will complicate with gastric emphysema, then the necrosis of the bowel, and then the perforation. So what the treatment they suggest is the NG tube insertion, so to decompress the stomach. Actually, I have seen 2 to 3 patients referred from the medical units because of this distended abdomen, suspecting intra-abdominal mass. Obviously, we see a distended abdomen and we see a palpable mass thing. So when we do the ultrasound, we see large distended stomach, which is actually the extending up to the pelvis. So the only treatment is the NG tube insertion. So the third entity for dilated stomach is the gastric volvulus. I have discussed 2 volvulus, and this is also very important. There are 2 types of volvulus: organoaxial and the mesenteroaxial. This is very bit confusing, right? Organoaxial volvulus, this is more common in adults, and mesenteroaxial volvulus are more common in children. And organoaxial volvulus means, if you see this first diagram, there is a line from fundus to pylorus, this line. So how this stomach rotates in organoaxial? In organoaxial, this stomach rotates along this line. Then what happens? The greater curvature goes up, the lesser curvature goes down. That is the feature in organoaxial type of gastric volvulus. This is usually associated with paraesophageal hernias. In paraesophageal hernias, what you see is the gastroesophageal junction is at the esophageal orifice. It don't move up like hiatus hernias, and the stomach goes through the esophageal orifice into the intrathoracic cavity, and this leads to this volvulus. I'll show you some X-rays, right? And the mesenteric type, mesenteroaxial volvulus usually seen in children. This diagram shows how this mesenteroaxial volvulus happens. It actually rotates other way around. That means the line perpendicular to the line drawn from the fundus to the pylorus. It's other way around. In this case, your gastroesophageal junction and the pylorus relationship, you need to look for this relationship. The pylorus situated above the level of gastroesophageal junction in mesenteroaxial volvulus. But in organoaxial volvulus, the relationship between the gastroesophageal junction here and the pylorus is fixed, same, right? In X-rays, you will see a dilated stomach in left upper quadrant or in intrathoracic. Left diaphragm may be elevated, and due to this volvulus, distal bowel loops obviously collapse, and you will see a air fluid level, right? These are some X-rays. The first X-ray, what is that? Is it organoaxial or mesenteroaxial? This X-ray, what you see? You see a, obviously you see a cystic, retrocardiac cystic structure in the intrathoracic level, right? And you see a fluid level. This is actually patient with organoaxial volvulus, where this stomach herniates with the paraesophageal hernia into the thorax. This is a organoaxial type. Here what you see? Here left diaphragm is elevated. You see a dilated stomach here, obviously, and you see a low air fluid level. And this is seen in intra-abdominal, not extend into the intrathoracic level. And this is a patient with mesenteroaxial volvulus. So we are actually not going to diagnose these in X-rays. So we do further investigation. We do actual upper GI contrast studies and CTs. So this is a third case, shows you first X-ray. First X-ray, you can see it's a supine X-ray, so you don't see a fluid level. This is the distended stomach. And the second X-ray, obviously you see a fluid level. And third X-ray, what is the third image? It is an upper GI contrast study. You do upper GI contrast studies for these patients. There is an upper GI contrast study with the NG tube. So where is the gastroesophageal junction and where is the pylorus here? The NG tube insert from here. Okay, this is the gastroesophageal junction, and the NG tube exit from here. This is the pylorus, and this is the duodenum. So this pylorus lies above the gastroesophageal junction. So this is a type of mesenteroaxial volvulus. So we, as I said, we need to do further investigation for clarify this. Right. Now we are moving into inflammatory conditions where you see X-ray findings. Okay. And I have thought to speak about three type of colitis. The ulcerative colitis. Ulcerative colitis is a type of inflammatory bowel disease, and actually all these colitis, you don't see specific signs. You see non-specific signs. But if you see these signs, you need to suspect that there is a colitis going on this patient. The one is the thumb printing. Thumb printing is a radiologically very important sign. Thumb printing means your impression of your thumb-like impression. right? If you see this drawn diagram, you see impressions here in colon. And I have put this normal X-ray to show you the normal large bowel, right? In normal large bowel, you see host regions. You don't see impressions. You see host region, right? In this X-ray, I don't know, you can see this X-ray here. This is the transverse colon, right? If you see closely, this transverse colon has a wavy appearance. These are the thumbprints, right? Here, these are wavy appearance. These are thumbprints. So in this crop image also you see thumbprinting. These are thumbprints, right? Not like host regions. So this is a very important sign in colitis. And the second sign is a lead pipe colon sign. Lead pipe colon sign, as name says, it is like lead pipe. The lead pipe means it's a featureless colon. You don't see host regions, right? Can you see descending colon in this X-ray? This is the descending colon. The orange color arrow is marked there. This is a descending colon. Do you see normal host region? No. It's like a lead pipe. So this is called lead pipe sign. This is seen in ulcerative colitis as well as in Crohn's disease. So you need to look for these signs. And other things are the toxic megacolon and sometimes pneumoperitoneum you will see as a complications, right? The other two types of colitis. In the pseudomembranous colitis, it's called antibiotic associated colitis because of the Clostridium difficile. It's a type of infective colitis. And the ischemic colitis means there is a vascular insufficiency and you get ischemia and you get it's called ischemic colitis. If you see the view of X-rays, you see no much difference. You see thumbprinting in both conditions, as I earlier explained, and as complication you will see toxic megacolon and the pneumoperitoneum. So what is the difference in these two in X-ray? The difference is the involved segment of the colon. In pseudomembranous colitis, usually whole colon is involved. So you see thumbprinting in the whole colon. But in the ischemic colitis, you see this thumbprinting, these changes only in splenic flexure. Why is that? Splenic flexure is the watershed area between the SMA and the IMA. And therefore, usually if you get a ischemic event, ischemia, you see a ischemia mainly at this level. So you need to see here this second X-ray shows you thumbprinting. Here thumbprinting in the splenic flexure. And this is a patient with pseudomembranous colitis. This is a patient with ischemic colitis. So as I told you, you need to look for this thumbprinting. And toxic megacolon, this is a complication of colitis and it's a severe complication and lethal complication. And so if a patient diagnosed with ulcerative colitis or Crohn's disease, if the patient come with acute abdomen and distended abdomen, you need to look for these toxic megacolon, right? The definition says you need to have acute colitis and also toxic features to say it's toxic megacolon, right? The causes are ulcerative colitis, Crohn's disease, infective colitis, ischemic colitis, radiation-induced colitis. All these leads to toxic megacolon. In X-ray is very easy. You will see distended large bowel. If you measure the diameter, it's more than 6 centimeters and mainly involve the transverse colon. And this first X-ray is belong to a patient with ulcerative colitis. Why is that? This X-ray has a lead pipe sign here. This is a patient with ulcerative colitis complicated with megacolon. And the second X-ray is a patient with pseudomembranous colitis. So you need to look for toxic megacolon. I have included these two conditions. Actually, acute appendicitis and acute pancreatitis, these are actually, we don't do X-rays to diagnose these conditions, but there are some X-ray features, right? Like in acute appendicitis, I discussed about sentinel loop. This is important. If you see a calcific density in RIF region in a patient, it's a most likely appendicular with clinical right with the right clinical settings. Clinical, if you suspect appendicitis, and you see a appendiculate in the X-ray here, the probability is very high. It's like 90%, right? And in acute pancreatitis also, the abdominal radiograph features I have discussed earlier: sentinel loop, colonic cutoff sign, and gasless abdomen. And the chest X-ray features are left-sided effusion is usually you see here. There's a blunting of costophenic angle in this erect X-ray, and also basal atelectasis, left hemidiaphragm elevation, and the ARDS. ARDS is acute respiratory distress syndrome. In ARDS you see air space shadows in either side of the lungs, mainly peripherally distributed, but we have to differentiate this from the pulmonary edema, because here there is no cardiomegaly. Right, so we have completed the first section, the abdominal bowel gas patterns. Now the second section, it's extraluminal air. So you have to look for air outside the bowel loops. Right, I have categorized into 4 topics: pneumoperitoneum, pneumoretroperitoneum, pneumatosis intestinal, and gas in the abdominal. So if there is a patient coming with acute abdomen, you need to look for these air within these areas. First one is the pneumoperitoneum. In pneumoperitoneum means air within the peritoneal cavity, and you need to have 2 abdominal X-rays, supine, erect, or left lateral decubitus. And even little as 1 milliliter of air you can detect in X-rays. So what are the causes? The perforated peptic ulcer is the most common causes, and these are the other causes. So what you see in pneumoperitoneum? In pneumoperitoneum, they have actually in books they have explained lot of signs, right? I have here I have included few signs which are important. The first one is the crescent sign, right? Crescent sign, the name says you see a crescent shape air lucency, crescent shape air lucency below the diaphragm. So you can see in either side of the diaphragms crescent shape air, and this is because of the pneumoperitoneum. It can be seen in the erect chest X-ray as well as the lateral decubitus film. So in this second X-ray is the lateral decubitus film. You can see crescent sign in between the liver, right lobe of the liver, and the diaphragm and the lateral chest wall. So if you suspect pneumoperitoneum, you have to take either erect X-ray or the lateral decubitus film. So there are mimics for crescent sign. That means these conditions can misinterpret as pneumoperitoneum. This is very important. So when you are describing, or when you are looking for a pneumoperitoneum or air under the diaphragm, you have always have to keep in your mind these conditions, right? The first one is the Chilaiditi syndrome. I think most of you all know Chilaiditi syndrome. Chilaiditi syndrome means interposition of the bowel loops, large bowel loops, in between the diaphragm and the liver. So this first X-ray shows a patient with Chilaiditi syndrome, where if you closely look at this X-ray, there are host striations in this lucency. Here you see host striations here. Here also there is a host striation. So you have to look for host striations, right? If there are host striations, that means this is a patient with Chilaiditi syndrome, not the pneumoperitoneum. Even that also you can't differentiate the air under the diaphragm and the Chilaiditi syndrome. What you have to do is you have to take the left lateral decubitus film. In left lateral decubitus film, you see, as in here, you see if there is pneumoperitoneum, you will see air like this. But in Chilaiditi syndrome, you don't see air like pneumoretroperitoneum. The second one is the subdiaphragmatic abscess. The second X-ray shows you the subdiaphragmatic abscess, where you see a air fluid level. Here you see a horizontal air fluid levels, not like air under the diaphragm. Air under the diaphragm, what you see? Air under the, you see curved, like, because liver contour is curved, right? Not like this horizontal line. This is a patient with a subdiaphragmatic abscess. The second case, the other causes are omental fat interposed between the liver and the diaphragm. The other one is subpulmonary pneumothorax. This is also very important. Subpulmonary pneumothorax means the third X-ray shows subpulmonary pneumothorax. In subpulmonary pneumothorax, the air accumulates between the right diaphragm and the pleura, right? So if you see this X-ray, you can definitely misinterpret as the air under the diaphragm. How you differentiate this from the air under the diaphragm? If you see this X-ray, air under the diaphragm is above the radiolucency. So, and the diaphragm is actually thicker than the parietal pleura. Normally diaphragm is thicker because diaphragm is made up of muscles and pleura is a thin line. So you see a echogenic thick line above the radiolucency. So it's diaphragm, that means you see pneumoretroperitoneum. In subpulmonic pneumothorax, you don't see a thick line, right? You see a thin line. So see here this patient actually has a lower lobe haziness, like means lower lobe opacification. Therefore, you can't clearly elicit this the pleural line. So if you see a thin line, it is subpulmonic pneumothorax. The large X-ray, the last one shows you patient with multiple bullae. All right. So if you have a bullae in the right lower lobe, this also can misinterpret the air under the diaphragm. The second sign, it's called regular sign. All right. The regular signs means what? It means you see either side of the bowel lobes. Usually in abdominal X-ray, can you see either side of the bowel lobe? No. You see only inner side of the bowel lobe. So if you see either side of the bowel lobe, that means air is seen outside the bowel lobe. And to see this, large amount of free air needs to be there, right? In these X-rays, you see thin line, echogenic line here and here. You can see inside and outside. Here also you can see either side of the bowel lobe. You don't see this in normal X-ray. So this is called regular sign. And the football sign is usually seen in necrotizing intragastric patients with pneumoperitoneum, and in the case of massive pneumoperitoneum. So you basically what you see is, you see a radiolucent area like a football, right? This is because this is actually seen in supine abdominal X-rays, where air collects anterior to the abdominal viscera, giving rise to this appearance, right? If you see this appearance, it's called football sign. Right, there are actually lot of signs, so don't get confused, right? And the next one is the falciform ligament sign. Falciform ligament sign, you don't see normal falciform in normal X-ray. So if this patient is having pneumoperitoneum in a supine film, you will see the falciform ligament outlined by the air. If you see this X-ray, there's a white color line extending from above downwards. Here also there's a green narrow white line. This is called falciform ligament sign. This is another sign of pneumoperitoneum. And the other sign is the cupular sign. Cupular sign is also very important. This is seen in supine chest X-ray or abdominal X-ray. And cupular term means that this comes from a dome, such as the famous dome of Dumo in fluorescence. Actually, if you see this picture, this is dome shape, right? This name came because of this. It's a cupola sign. If you see this X-ray, you will see a curved shaped, dome shaped, right? Dome shaped air lucency below the cardiac shadow in lower thoracic level. If normally you don't see a curved air lucency here. This is because of air accumulate under the central tendon of the diaphragm. This is called cupular sign. And the continuous diaphragm sign. The continuous diaphragm sign means it's easy. You can see diaphragm continuous. You don't see diaphragm continuously in a normal X-ray, because the mid part of the diaphragm usually you don't see, because the heart and the liver the silhouetting the mid part of the diaphragm. Here what you can see, it's a continuous. You can see continuously this diaphragm here. This is called continuous diaphragm. This is seen in erect X-ray. And the last sign in the pneumoperitoneum, it's called triangle sign. This is a subtle sign, and you will see this in supine node decubitus abdominal film. As the name says, you will see triangle lucency here in between the three bowel loops, or here and here in between the two bowel loops and the abdominal wall. This is a subtle sign. This is called triangle sign. So these are the signs that describe pneumoperitoneum. So moving into pneumoretroperitoneum. Pneumoretroperitoneum means air within the retroperitoneal cavity. So what are the causes? The most important thing is perforated retroperitoneal hollow structures, duodenum. If it is duodenum, peptic ulcer disease, trauma, ERCP, etc. If it is ascending colon or descending colon, colorectal carcinoma, diverticular, ischemic colitis, those things are the reasons. The second important thing is the gas producing infections. If you have a patient with emphysematous pyelonephritis, you will see pneumoretroperitoneum in X-ray. So in plain X-ray, you will see streak linear appearance. I will discuss this with the images. Streak linear appearances outlining the retroperitoneal structures, and your short shadow get absent, and you see relatively fixed position. The first X-ray. This is a X-ray with left side pneumoretroperitoneum, where you see here outlining the kidney, you see air lucency. Usually you don't see this black color air lucency around the kidney. So in this part, this side of the abdomen, you don't see it. Right? This is air outlining the kidney. This is because of the pneumoretroperitoneum. And also you can see the air in this peritoneal reflection. This is a patient with left side pneumoretroperitoneum who's had the descending colonic perforation. And the second X-ray is a patient with emphysematous pyelonephritis. This patient, you see a edematous kidney, right, and mottled appearance. Usually, as I described in the normal X-rays, the kidney is like gray appearance. Here you see mottled black color appearance and a edematous kidney, and you see a curvilinear air lucency outside the kidney in the perinephric space. This is a patient with the patient with emphysematous pyelonephritis, and this patient has also, if you see closely, here either side of the vertebral column, there is a black line here, right, outlining the psoas muscle. This is due to pneumoretroperitoneum. Right, this patient with emphysematous pyelonephritis. The third case, actually, patient from here, the surgical wards. This patient actually referred from the surgical wards, and we actually saw intraperitoneal fluid in ultrasound scan, and we went through the X-ray, and X-ray shows multiple streaky shadows here. These all are streak shadows, and you can't see psoas shadow clearly. Psoas shadow you can't see, and you can see multiple streak shadows. This patient found to have duodenal perforation. So this is the case of pneumoretroperitoneum. And I'll quickly discuss about the pneumatosis intestinalis. This means air within the bowel loop. So I have discussed air within the peritoneal cavity, air within the retroperitoneum, and now this is air within the bowel wall. There are a lot of causes, but this is very important because some of these causes are life-threatening, like intestinal ischemia, intestinal obstruction, enteritis, colitis, toxic megacolon can give rise to this sign. Right? Okay. In plain radiography, you will see linear lucencies or round bubbly collection in abdominal wall. These two are actually preterm patients with necrotizing enterocolitis. If you see closely, these bowel loops are dilated. These are bowel loops are dilated, and but what do you see in the wall? Wall is thickened. Wall is thickened, and you see radiolucent black color line surrounding the bowel wall. Here also you see these are due to air within the bowel loop. In these patients also you see streaky air shadows in the bowel loops. This is a patient with necrotizing enterocolitis, and this patient also having a tiny radiolucent shadows in the liver. These are due to air in the portal venous system. Right. Next topic, air in the abdominal organs. Right, under this topic, under this I will discuss this, and this is one of the important thing, pneumobilia. Pneumobilia means accumulation of gas in the biliary tree. So the most of the causes are benign, like sphincter of the incompetence, reason instrumentation, and also some of these causes are life-threatening, like cholangitis and emphysematous cholecystitis. In radiography, what you see is, in radiography, you will see branching radiolucencies mainly in the central part of the hilum. Mainly these seen in the hilum of the liver. That is the most important thing, because you have to differentiate this from the within the portal system. So in pneumobilia, you see branching shadows, air lucencies, mainly in the hilum. And here you will see another lesions because they are within the CBD. And This is I discussed previously. This is a patient with gallstone ileus. So in portal venous AR, you need to differentiate this with the pneumobilia. Because why the AR lucences are why in the seen in the hilum region. This is because bile flow is towards the hilum. Bile flow is towards the hilum, so AR is seen towards the hilum. And in portal venous, this AR in the portal venous system, the blood in the portal venous system, where the direction? The direction is hepatopetal. That means towards the periphery. So that's why in portal venous AR you will see AR lucences in the peripheral part of the liver, and these lucences are very thin, not like pneumobilia. In pneumobilia you see like large radiolucences. In portal venous AR you see small AR shadows. And some word about emphysematous cholecystitis. Emphysematous cholecystitis is a rare form and is life-threatening, and you will have gallbladder necrosis. It's a surgical emergency, and you can see AR outlining the gallbladder wall, right? A contour of the gallbladder you can see. If you see here, you can see a radiolucency line around the shape of gallbladder. This is a patient with emphysematous cholecystitis. And emphysematous pyelonephritis actually I discussed earlier, right? I put this X-ray to differentiate this from the emphysematous pyelitis. Emphysematous pyelonephritis means it is a life-threatening condition, and it's usually seen in diabetic patients. And the emphysematous pyelitis is a benign condition where this is associated with the urinary tract infection. And in emphysematous pyelitis you see AR within the excretory system. That means AR you see in the calyces, ureter, and sometimes in the bladder, right? So you don't see AR in the parenchyma. These patients are actually benign rather than emphysematous pyelonephritis. So you have to differentiate these two. And the last one is the emphysematous cystitis. That means you see AR in the bladder wall, right? Like gallbladder wall, AR in the bladder wall. You can see here radiolucent line in a contour of the bladder. Okay. Now we are moving to tissue masses. Now you have only few slides, right? The third topic is tissue masses. So if you see an acute abdominal patient, and sometimes you on examination you will see intra-abdominal masses, right? In that case, how you see these in X-rays, right? If you see enlarged organs, then you can see directly the visualization of the edges of the structures. So this first X-ray shows you what is this? Enlarged spleen, right? The lower border of the spleen you can see. So every time you need to look for lower edge of the liver and the lower edge of the spleen. If there is a hepatomegaly, you see lower edge of in this patient the liver is normal. In a hepatomegaly patient, you can have the lower edge of the liver down. Then here the patient with a splenomegaly, you will see a lower edge going down. Another thing is the indirect displacement of the bowel. Indirect displacement of the bowel indicates that there is a space occupying lesions is there. So in this X-ray, you will see you can't see bowel loops in pelvis, right? Because there is a opacity here, large opacity, soft tissue opacity. This is actually displacing the bowel loops. This is found to have a pelvic mass. And the last X-ray, this is a patient, a child. Actually, if you see this X-ray, what do you see? You see this X-ray, you don't see the normal the bowel loops in left side of the abdomen. This is a large opacity here, and this opacity pushing the bowel loops. So you can see this, there is a intra-abdominal mass here, but you can't say the underlying etiology from where this is arising from. For that you need to do ultrasound and CT. This is actually a patient with Wilms tumor. This patient had a large left renal mass, and that is the reason for this X-ray. So the final topic, calculi and calcification. So out of the calcification, I will discuss about the urolithiasis and the gallstones, because in Mahiyanganaya you will see lot of calculi disease, and in urolithiasis you see there are 5 types of calculi. The calcium-based calculi is true-white calculi. Calcium-based calculi are the most common. They account for 70 to 80% of percentage, and these are radio opaque. And this true-white calculi means it's a triple phosphate calculi, magnesium ammonium phosphate, and it accounts for 15%. And this is the main cause for this staghorn calculi. So most of the staghorn calculi are true-white calculi, and this is associated with infections. The third type of calculi is the cystine calculi. It is also radio opaque, and you can see in X-rays. And the fourth type of calculi is the uric acid calculi. This is not radio opaque, this is radiolucent. You can't see this calculi in the X-ray. And medication related calculi are also there. These calculi actually you can't see in X-ray and even CT. These are actually seen in IVUs as a filling defect. Right, and 90% of the urinary calculi are radio opaque, as I said. So you can see 90% of calculi in X-rays. So in the first three are radio opaque. So we'll go to some X-rays. The first X-ray, you can see there's a radio opaque density overlapping the projecting in the area of the left kidney. So this is a calculi. Actually, it's specifically speaking, it's a lower calyx calculus. The second X-ray, you will see a large radio opacity taking the shape of the calyces, right? If you see this, it's shaped take the shape of the pelvis and the calyces. It's a staghorn calculus, and also some non-obstructing calculi are there. The third X-ray, there is a if you see closely, there's a tiny radio opacity here. This is the ureteric calculus. So if you are looking for ureteric calculus, you need to know the pathway of the ureter. So what is the pathway of the ureter in X-ray? So ureter usually goes from L2 to L3 levels just medial to the tip of the transverse colon. So you have to look for just medial tip of the transverse colon. This calculus is like just medial to the tip of the L3, and also in front of the SI joint, and ultimately it turns at this spine, scale spine. So there are several mimics for urinary tract calculi. Gallstone, pancreatic calcification, calcified mesenteric nodes, and renal artery calcification. These are actually mimics for renal calculi. So you have to, every time you see a renal calculus, you need to have your mind, these can be the reason. So the first and second X-ray shows gallstones. Here these are gallstone, and here this is a single gallstone. How you differentiate renal calculus from the gallstone? What are the features? Usually the gallstones are faceted, right? They are round shaped, right, because of the gallbladder. And the renal stones usually take the shape of calyces. They are like oval shape or shape of calyces, right? Usually calcified gallstone are, if they are multiple, they are seen as clusters, and renal stones, they are located apartly, right? And even after that also, if you can't differentiate a gallstone and a renal stone, then what you are going to do? In anteroposterior view, you can't diagnose gallstone and the renal stone. Then you have to do a lateral X-ray. Yes, lateral X-ray. You can easily remember gallbladder is a retroperitoneal structure. It's not a retroperitoneal structure, gallbladder. So you will see a gallstone anterior to the vertebral column because of gallbladder is not a retroperitoneal structure. But kidney is a retroperitoneal structure. If there is a renal stone, you see this density behind overlapping the vertebral column. So that is very important to differentiate the gallstone. So the first X-ray, this density is the calcified mesenteric lymph nodes. So if you have doubt about this, you have to definitely do the ultrasound or NCCT KUB. Last two X-rays I have put you to show the phibboliths. Phibboliths, you usually see phibboliths, and you confuse this with the ureteric calculi. So you have to differentiate this phibboliths with the ureteric calculus. How we are going to differentiate? The phibboliths here, the phibboliths are usually rounded shape, but ureteric calculi are, because ureter is a tube-like structure, so the most of the time these stones are elongated. So the fibolits are round shape, and in fibolits you see radiolucent center, because what does mean fibolit? Fibolits means the calcification of the venules, pelvic veins, right? This leads to this density. So you see because of the wall calcification, you see a radiolucent lumen. So this is another differentiating feature, and usually fibolits are multiple, right? But not ureteric calculi. And I have put 3 slides to show you some calcifications which are clinically important. The first X-ray shows the patient with porcelain gallbladder. There you see calcification taking the shape of the gallbladder. This is a patient with porcelain gallbladder. So it is actually associated with the increased risk of gallbladder carcinoma. So so this is very important. The second X-ray, this one, if you see here, you see multiple irregular shape calcification taking the shape of the pancreas and in the position of the pancreas. This is a patient with calcific chronic pancreatitis. So if there is a patient coming with acute abdomen and you in the X-ray you see this calcification, then you have to look for acute onset chronic pancreatitis. The third one, if you see, you can see calcific line here and here, right here. In here they have labeled it, and this is the aneurysmal calcification. So if a patient comes with a severe abdominal veil, always you need to look for aortic aneurysms and the dissections. So if you have an X-ray, you need to look for because most of the patients are coming with elderly patients, so they are the aneurysm wall is calcified, so you will see a calcified wall. And this is the last slide, right? Following the history and the clinical examination, plain radiographs have been one of the first and most useful method of the further investigation, and plain radiographs continues to be the initial imaging modality in acute abdomen, and particularly in the bowel perforation and obstruction, they play a significant role. Thank you.
We are open for questions from our attendees today. Is there any questions you'd like to ask Dr. Buddika? Anyone? Any more questions? Well, thank you, Buddika sir, for this comprehensive lecture, which I'm positive is much more than beneficial for our attendees today. I'd like to remind all of you about our website, official website, www.csbhm.bp.com, for easy access to the lecture notes and much more. As we move forward to the next segment, the quiz, we expect great enthusiastic participation from our attendees. The questions will be put up on the screen before you, and you get 45 seconds to answer each question. We've shared the link in the group. Kindly please join to it. Toward the winner, Dr. Teshani Hera. Sir, I would once again like to call upon Dr. Buddika Hera to discuss the questionnaires with our audience. Sir.
First question, what is not a mimic for air under the diaphragm? What is not a mimic? Agility syndrome is a mimic, lower lobe bulle is a mimic, subcapsular effusion not a mimic, subdiaphragmatic abscess is a mimic. The second question is what is not a mimic for air? Second question, which X-ray is helpful in detecting small amount of intraperitoneal air in a patient who cannot stand? Here you have to look for patient who cannot stand. So erect chest X-ray, supine abdominal X-ray, left lateral decubitus, right lateral decubitus. The left lateral decubitus. If patient can stand, then you can do erect chest X-ray. Right? The answer is left lateral decubitus. Yeah, left lateral decubitus means left side is down. Then the air seen between the liver and if you do other way around, you can't see air between. There should be a solid one. Third question, which of the following is false? 2-3 fluid levels in small bowel are abnormal. 2-3 fluid levels in small bowel normal. Large bowel, that is the answer. Large bowel has no fluid levels, true. Almost always they are in the rectum, true. Maximum normal diameter of cecum is 9, true. Right, the answer is A. What is radiolucent renal stone among following? The citrines radiopaque, uric acid is the answer. Struvite and calcium oxalate are radiopaque. And answer is B. And what is correct about large bowel volvulus? Correct. Coffee bean sign is a feature of sigmoid volvulus. It's correct. Cecal volvulus is the commonest no. Sigmoid volvulus shows no ostration. Actually, it's also correct, right? There are two answers. Right? While going through this MCQ, I saw this fault. Actually, both of these are correct. Right? Freeman-Dahl sign is seen in cecal volvulus. It's wrong. Seen in sigmoid volvulus. Right? The next one, what is false about radiographic features of small bowel obstruction? What is false? Small bowel diameter should be more than 3 centimeters. And a string of what is for the radiographic features of small bowel obstruction? The first one is correct. And the string of Pearl sign is diagnostic of small bowel obstruction is correct. Gasless abdomen is only seen in SBO. It's wrong. That's the answer. And centrally placed dilate loops, bowel loops with valvular connivantis. It's true. So answer is C. The question 7. What is false about plain radiographic findings of colitis? Thumb-printing is a feature in pseudomembranous colitis. It's true. You see in every colitis. The second one is splenic flexure involved in ischemic colitis. It's true. Lead pipe sign is only seen in ulcerative colitis. That's the answer. It's wrong because it's seen in Crohn's disease as well. Dilatation of colon more than 6 cm is seen in megacolon. It's true. So answer is C. The question 8. Which of these is not a sign of pneumoperitoneum? It's obvious. Naclerio V sign. It's seen in actually pneumomediastinum. It's a V-shaped sign. It's seen in the pneumomediastinum. But other signs are seen in pneumoretroperitoneum. And false about pneumobilia. It is a feature of gallstone ileus. It is a feature of gallstone ileus. It's true. Cholangitis is a cause true. It can be differentiated from portal venous air from Xray. It's true. Multiple branching radiolucence is in periphery of the liver in Xray. It's the answer. It's wrong. And answer D. The last question. What is true among following statements? Sentinel loop is seen in right upper quadrant region in acute appendicitis. It's false. Presence of appendicular in a X-ray with right clinical settings tells probability of appendicitis is high. This means low. The answer is wrong. And gasless abdomen is seen in high bowel obstruction. That is true. Colonic cutoff sign is not a feature of acute pancreatitis. There is a fall. You see colonic cutoff sign in acute pancreatitis. So answer is C.
Thank you, sir. I'd like to now call upon Dr. Samir Ratnayaka to present Dr. Buddika Rathninda the token of appreciation. As we come to the end of yet another fruitful session, I take this opportunity to sincerely thank all who made this a possibility and a success. Dr. Buddika Rathninda sir and his entire radiology department, Branch Union Government Medical Officers Association, and our sponsors for today, Astron Pharmaceuticals. I'm sure everyone here today is eager to find out about our next session, the 11th one, which will be on the 8th of August, conducted by Dr. Lochana Samarasinghe, consultant psychiatrist on the management of alcohol use disorder. I once again would like to thank you all for your presence. Hoping to see you in the next session. Have a pleasant day. Thank you.